Welcome to today's webinar on scaling index testing and partner notification for HIV epidemic control, engaging hard-to-reach clients in the continuum of care. My name is Teresa Russo, and I'm the web manager for AIDS Free. Before we begin today's presentations, I'd like to quickly review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 3 presentations, followed by a discussion period during which our speakers will address your questions. Your microphone will be muted during the presentation. Please make use of the chat box on the bottom right side of your screen to connect with other participants, share your thoughts, or ask questions during the presentation. We will gather all of your questions in the chat box for our question and answer period. If you find the chat box distracting, you can click on the full screen button above the slides to display only the presentation slides. Following our presentations, we will move into the discussion and questions and answers section. We will answer as many questions as possible during that period. It's great that we're able to connect people from so many places today, but your experience may vary based on your internet connection and computer equipment. I'll briefly go over a few troubleshooting steps if you have technology challenges today. A few troubleshooting tips. If you use connectivity or cannot hear, close the webinar. Re-enter the meeting room in the browser other than Google Chrome by clicking on the webinar link provided. Use the chat box to ask JSI Tech for assistance. If the troubleshooting steps are not successful, please rest assured the webinar is being recorded and you will receive an email with a link to the recording following today's event. Questions that are not answered during the Q&A section will be compiled after the webinar, shared with presenters, and responses from presenters will be shared with participants. Today, our moderator will be Barbara Durr, who is the Director for Country Programs with AIDS Free. To get us started, I'll now turn it over to Barbara.
Thank you, Teresa. Welcome, everyone, and thank you for joining us today. Again, my name is Barbara Durr, and I'm honored to be with you today to discuss index testing and partner notification. During the next hour, we're going to highlight 3 very innovative projects which JSI implements with USAID: the Discover Health Project in Zambia, the Strengthening the Care Continuum Project in Ghana, and the Global AIDS Free Project. As we all know, index testing and partner notification are core interventions to identify HIV-positive individuals efficiently and effectively. We also know that achieving quality, scale, and fidelity in service provision remains a challenge in most of the countries in which we work. Today, we hope to learn with and from one another on how to address these challenges. So now, without further ado, it is my great pleasure to introduce our first speaker, Dr. Kalesa Mwande, who is the Deputy Project Director for Clinical Services for the USA Discover Health Project in Zambia. Kalesa will lead us through JSI's experience with HIV index testing within an integrated health service delivery program. Kalesa, so glad the technology worked, and over to you, my friend.
Okay, thank you very much, Barbara, and hi, everyone. Well, I'll talk briefly on the work that we've been doing on the USAID Discover Health Project in Zambia. So first and foremost, as we scroll through the slides and familiarizing with the technology, I think it's actually fully working now. I'm able to control the slides by myself. So Discover Health is a 5-year project which was funded in 2015, and it's set to actually go all the way up to December 2020. We have 2 broad objectives. The first one being to ensure high-quality integrated health services are being used more by the target populations. And our target groups can be varied, but largely those that are underserved, even to this age in the epidemic control in Zambia. So basically, under this particular objective, we provide an integrated package of HIV, family planning, reproductive health, and maternal, newborn, and child health services. And then for going further on this particular objective, we also provide predominantly services in outreach through outreach facilities that actually spring from 11 hubs across the country. Altogether, we have about 138 sites. We recently were given 2 big hospitals that were handed over to us from a CDC-funded project, and these are acted on the cover belt, and both of them are main hospitals. Under the second objective, our objective is essentially to provide integrated health products and services in a sustainable manner. And these products are essentially socially marketed and largely speak to the provision of services in the area of HIV, AIDS, family planning, reproductive health, and MNCH. So going forward from there, I would like to mention that indeed, broadly speaking, the services we provide on top, of course, you find HIV testing services, and these are the backbone of all services that we provide under the project. Be it child immunization, we enshrine testing. ART, of course, for one to access antiretroviral therapy, one has to be tested. PMT, CT, MNCH, family planning, voluntary medical male circumcision, all these are actually supported, and indeed we start with HIV counseling and testing. For this particular reason, I'll share a few things that speak very strongly to HIV testing services. Our testing services are actually done through a number of modalities.
Kalesa? Did we lose him?
I think we may have just lost him.
Oh dear. Well,
let's give him a second to try and dial back in, and if it takes longer than a minute or so, maybe we'll move on to the next presentation and he can continue when he gets back. But let's give him a minute or two.
Kalesa? Oh, welcome.
Hi, everyone.
You're back.
Oh, perfect. Yes, certainly. All right, so I'll pick it up from my left. Sorry about that poor connection. So top on our list are HIV index testing and partner notification services. And then the other modalities are, of course, things that we've been doing, I think, for so many years now in an attempt to control the HIV epidemic. And these include voluntary counseling and testing, provider-initiated testing and counseling, ANC, each and every mother that comes in pregnant into the clinic, we avail them an opportunity to know their HIV status. And then, of course, voluntary medical male circumcision. The package in Zambia, like a lot of other African countries, is for VMMC to enshrine counseling and testing. In fact, the basic purpose is actually to prevent HIV. That's why the men and the boys are being circumcised. So before the circumcision is offered, as part of the package, counseling and testing is actually provided. So indeed, in as far as HIV index testing is concerned, our rationale is picked from the fact that this is a clinically proven intervention, especially going by the randomized clinical trials that were done in different countries, including Kenya, Tanzania, Malawi, and indeed Cameroon, where it was found that the yield, HIV positivity yield for HIV indexing and partner notification can be as high as 35 to 62%. And it is indeed against this particular background and placing it against our scenario here in Zambia, where we find that a good number of people, over 30% of people, still remain untested, especially going by their recent results within the last 12 months. We find that with the men, about 36% of them do not actually know their current HIV status. And for the women, about 82% do not have an idea whether they are actually positive or indeed negative. But also, at a time such as this one, when Zambia is poised to attain epidemic control by the year 2030, we find ourselves in a space where out of a population of about 15 million people, 1.2 million people are living with HIV, and out of which basically about 300,000 have not been reached with antiretroviral therapy or indeed ART services. So really, this increases the need to be very targeted if we're going to reach out to these people who are spread out in so many small pockets and indeed diluted by this large population. And then also we are faced with the reality that the donor, USAID, the US government, demands now more than ever before more efficient use of HIV test kits and other consumables that are related to that. But over and above all these, we have a huge target within the project of actually placing on treatment about 80,000 people by the end of the year 2020, which is basically end of next year. Right now, I'm glad to share, even as we talk about indexing, that we are basically over 53% towards this particular target. Talking about a few statistics in relation to HIV indexing and our program in Zambia, we find ourselves in a space, of course, having provided HIV indexing for some time now. We are at 23% positivity in as far as HIV indexing is concerned. And around this particular statistic are fairly well-documented statistics as well, including the fact that if we look at the first bar in this particular graph, we have, for instance, between April 2018 and indeed February 2019, we had about 8,500 people that accepted to be indexed. I would like to use this term loosely. I know if you look at, check through the dictionary, maybe this particular one hasn't been included yet, but really within the project, and you would understand, but where you don't, please, you are welcome to ask at the end of the presentation or when the time comes to ask questions. But really, accepting to be indexed, we have about 8,500 people. And out of these, we did manage to get to over 14,300 contacts. These particular contacts, of course, include adults as well as children who are actually biological children to the adults that were first contacted. I should also mention that out of the 8,500, some of these were actually children under the age of 12 and were able to reach out to their siblings who are in this particular bracket, to ensure that they come to know, especially for the guardians, they come to know what the HIV statuses for these children are. So out of 14,300, were able to actually reach 11,700 contacts that actually accepted to be tested. And out of these, the majority were negative to the tune of about 9,000 people, and about 1,000 tested positive, giving us a positivity of 23%, like I mentioned. One good thing with indexing is that most of those that test positive do actually accept to be linked to care, principally because they are also being spoken to by the initial or indeed the index client. So already the ground is fertile, and indeed accepting antiretroviral therapy becomes easier. So even in this particular case, 88% of all those that tested positive ended up being initiated on treatment. One thing that I would like to show coming out of our project data is that index testing gives us the highest positivity yield compared to all the other modalities that I shared with you a couple of slides ago. If you look at ANC, we are 4%, while indexing stands tall at 23%. VMMC is the lowest, less than actually 1%, standing at 0.1%. VCT Of course, this will start, we've been doing VZT for a very long period of time in Zambia, close to 3 decades, but really positivity cannot be compared to indexing. Now, something of key interest, especially at a time such as this one, and responding to our epidemic in Zambia, where more men remain untested compared to women, and then also the fact that the well man becomes very, very difficult to reach out to, and bring into care. With indexing, something that we've noticed even from our data is that the proportion of contacts that are tested out of going through the contact list, elicitation with the index client, the contacted, the contacts to the index clients, most of them are actually male. 51% are seen in the pie chart compared to 49% who actually happen to be female. Now, delving further with the earlier statistic of 51 to 49%, we are also reminded of the fact that more females are actually, affected, so to speak, in terms of HIV status, in as far as the HIV epidemic is concerned. From all those that we test, there's a higher proportion of those that turn out to be positive are actually female, to the tune of 53%, compared to males to the tune of 47%. So indeed, we reach out to more males through index testing in as far as the contacts are concerned. But out of those contacts, all those that test positive, there's a higher fraction of women compared to men. All right, at this point, let me connect this to the earlier indication of the fact that we do not just reach out to the adults, we're also reaching out to the children. Of course, we know for a fact that most of the children do actually contract HIV from their HIV-positive mothers. So it is prudent whenever we find an HIV-positive mother that we inquire about their children. And out of this particular practice, which is actually an aspect of HIV index testing as well, within a period between April 2018 and February 2019, we reached out to almost 4,100 children. Out of these, 255 were positive, giving us a positivity yield of 6%. You would like to know that ordinarily, especially when we consider VCT, positivity in children is much, much lower. In our setting, way lower than actually 2%. But when we index, we get to 6% for the children under the age of 15 years old. For the adults, ladies and gentlemen, we find that for the period that we are sharing results for, we reached out to about 4,075 adults. Out of these, about 1,600 were positive. So indeed, giving us a positivity yield of 41%. You would like to know that indeed average of 23%, but largely that is being diluted because of the influence or the input from the data among children. If we consider adults alone would have a positivity of actually 41%. The average, of course, comes down to 23%. All right, what was between males and females? We find that, and perhaps this is not very surprising, we find that there's always a better linkage with the females compared to the males, all right? And we can see through various age bands and that the females are better linked compared to the males. Although indeed, in this particular setting of, index testing, the males are not doing so badly compared to maybe voluntary counseling and testing, mobile counseling and testing, and so forth. Basically because we see that generally across all age bands, even the males are actually over 80%. And most of these statistics actually show us above 85%. All right, within the project, we have actually embarked on a very aggressive strategy now, especially that we would like to push index testing to scale. For sure, it is now a known fact, and we're glad to have been part of this movement, even within Zambia, to actually share the knowledge about HIV index testing. And a lot of other partners have also come to believe that index testing is the way to go. But where we are perhaps missing it and required to make some serious improvements on is how to turn the numbers round from indexing very few numbers to be able to index a lot more. And in the past few months, and you can see from the graph, the sharp projected increase from 3,100 to 4,100 thereabout, that is actually projected by the time, because the March results we do not have, but perhaps we even do better than what has been projected. So what we're doing is to ensure that each and every client that is positive in our sites, especially those that were tested or initiated on treatment the last 6 months, we allocate the files to our community health workers, to our pool of health workers at facility level. And each of those clients is given an opportunity to be indexed. Indexed in quotes, because it's not perhaps a conventional way yet, but really to be given an opportunity for index testing on each of them. And we are seeing results already. In most sites, the percentage of people that are tested positive seems to be increasing from the initial findings to what we are actually seeing as more contribution towards HIV indexing. Within the project, we have got a target, one, to ensure that by March next year, 2020, at least 40% of all those that test positive at a project level should have actually come from HIV index testing. If we're able to do this, then indeed would have demonstrated a very cost-efficient use of test kits, but also will be spending the resources where it matters the most, especially against the backdrop of an emphasis on reduced, indiscriminate testing, which has proven to be quite costly for the country. So really, if you look at this particular graph, we come from contribution by indexing of 8.8% in April to June 2018. And as we stand right now, in January to February 2019, we are at a tangible high of almost 14%. We would like to push this 14% to 40% by some of the, through the use of some of the strategies that I've already mentioned, including ensuring that each and every client is actually index tested and you get through to their partners. So a few programmatic lessons as I bring this to a close. First and top on the list is the fact that adequate capacity building among community health workers, healthcare workers, as well as counselors in HIV index testing is an absolute imperative. So far within Discover Health Project, we've trained over 825 healthcare workers as well as community health workers in HIV index testing. And we keep retraining as the need for replenishment arises, and also as we face the risk of attrition in some areas, but also taking up perhaps more satellite sites, already under our 138 sites. So this is a continuous process, ensuring that the capacity is built, but also responding to the dynamics on the ground. Where we see particular challenges in certain areas, we go in and provide mentorship, on-site mentorship, to the providers as well as the counselors. Continued mentorship, like I've mentioned already, and indeed our working model that does not need to be static. When we started off with HIV index testing, we never had this figure of 40% in mind, but we have seen, and this I think we are seeing to a greater extent, in a lot of our sites, that if you place a requirement and people do have a very clear target, they are working towards that particular target of ensuring that the contribution from indexing is as high as 40%. Everyone is more or less warmed up to this particular target, and everyone is pushing in one direction for the purposes of achieving it. And then lastly, but of course not the least, HIV index testing has potential to help extend HIV testing services to the well man, the man who is not sick and is physically okay, so to speak, has no opportunistic infection, and going to a facility, going for an HIV test might actually not be any one of his priorities, if you check a priority list. And now reaching out to this particular well man, we have seen that, of course, if we use index testing, we stand a greater chance to reaching out to the men, especially those under the age of 35, who have actually proven to be quite difficult to reach out to with traditional modalities of testing and providing HIV in
Thank you, Kalesa. Really appreciate that, and I think that we're all very interested in learning how we can reach men, and so your presentation is really important. I would like to remind folks to please add your questions for Kalesa in the chat box for our discussion afterwards, because we do want to hear from you and we want to have a rich discussion. Our next presentation is from Dr. Henry McGay, who is our Chief of Party for the USAID Strengthening the Care Continuum Project. Henry is going to present JSI's experience in Ghana working to provide HIV services in key populations. Henry, welcome, and thank you. Over to you.
Thank you very much, Barbara, and greetings from rainy Accra. Thank you very much, Ghana. I'm going to present our process and what we did to introduce index testing in our key population program. We in Ghana, just for the epidemiology of HIV, it's considered a generalized epidemic of prevalence of 1.7, but we have high prevalence among female sex workers of 6.9 and about 18% among MSM. The project is a 5-year project supported by USAID, and it focused on key populations, MSMs, male sex workers and their non-paying partners, and transgender people. We work in 5 of the 16 regions in Ghana, and we started with 21 districts, and those districts have been reduced to 14 priority districts. We are working with local indigenous civil society organizations. There are 13 of them who provide services at community level. As part of the goal, we supported the government of Ghana, who is leading the response in terms of the general population. Among the key objectives that I would like us to remember is the increase in terms of access and uptake and retention in HIV continuum of care services, which has been a relatively new objective for the entire country in terms of focusing on retention in HIV continuum of care services. Among the key strategies we have is integration of services and focus on referrals to achieve the 1990 targets. Starting from 2016 for the project, we realized that we have to increase yield. Civil society organizations at the community level continue to use different approaches. We realize that USAID, because of low yield from some of the districts in the previous project, actually dropped the number of districts to 11. So the need to look at different approaches and a strategic mix of these approaches to improve yield became very paramount. So what we did was to conduct microsite typology analysis and segmentation of our beneficiary population. We actually engage in rechecking and rethinking the basis and the targets, and conduct in-depth analysis to actually understand the needs of existing networks of sex workers and MSM. We also already had in place what we call social network testing, where we have a cohort of members of key population network and target their leader, able to conduct testing among that social group. That gave us some idea if the introduction of index testing was going to be successful. We had a situation where we do not have index testing as the national protocol, as it were. And so our introduction has been relatively noiseless, if you like, and coming from the need at the level of the community actors who were exploring and looking for opportunity to increase yield. Now, in terms of our approach, we have had 5-stage analysis of data, engagement of the civil society partners, indigenous organizations or KP-led organizations, and trying to understand what we can do in terms of index testing and other approaches to improve yield. We conducted orientation of organizations and integrated these orientations and training into the activities and approaches that were being used by the civil society organizations. We had to review tools, as it were, because we want to make sure that this is seamlessly integrated and accepted by members of the community organizations. We have had a situation in Ghana, just like many countries in West Africa, where marginalized populations, MSMs, and FSWs are stigmatized. There's a lot of discrimination and homophobia. And the project do not want to be directly or indirectly part of these challenge, especially when it comes to health services, because as we all know, the most severe form of injustice is self-injustice. And we don't want the introduction of partner notification and elicitation of partner information and filling of partner index forms to become a challenge, where we were seeing the already friendly environment for key populations. So we decided to do this seamlessly, and from the viewpoint of civil society organizations and members of the KP community. So basically, and we know this particular slide, one of the classic slides that we have. For the project, we're looking at the HIV positive index the key population living with HIV and the biological child in terms of the sex or the sex partner. Our program do not have, we don't force people to get drugs. A key component of the approach that I would like to emphasize here is the component of those who have accepted index testing. If you look at the green second line, this is very critical in terms of integrating index testing when it comes to key populations, because of the process for contact tracing, the process for disclosure, and making sure that the language and the tactics and the approach to disclosure is culturally and linguistically acceptable. And in the key population program, these are very critical at the community level, and partners will have to be trained and ensure that they can adapt the tips and the soft skills that are required to ensure that there is notification. We, at the community level, we are led by civil society organizations who organize in this case activities and conduct various approaches to reach beneficiaries. We have case managers who work also at facility level. Now, what has been the impact? When you look at this graph, when we introduced index testing, in addition to other new strategies, there was an increase in terms of the yield, which the project has been very happy about. When you look at this graph from the
Henry, I'm just gonna remind everyone to please mute your microphone because we are getting a little bit of a problem with hearing you sometimes. So if anyone has their microphone on, please mute it. Thanks. Go ahead, Henry. Sorry to interrupt.
Thanks, Barbara. So if you look at financial year 18, quarter 3, there is a reduction in terms of yield of MSM from 16, about 70% to 11 in the first quarter of 2019 financial year. And this actually is attributed to, we had a slowdown notification from USAID in terms of funding, and so we have community actors are not working. We have some case managers and peer educators who have to stop working for a period. I must add that the cadre of people that we trained and oriented included the executive directors of the civil society organizations, because we realized that we have to deepen their understanding and buy into index testing, and to assure them that this is not going to create more problems or more stigma. We also train case managers and nurse counselors, and also lay counselors. Lay counselors recently became a part of the set of cadre of workers for HIV services in Ghana because of the adoption of the shifting shifting policy, what we refer to as tax shifting, or in Ghana we call it tax sharing policy. And so lay counselors became part of the cadre of workers that we are using. When you look also into this on this slide, we were looking at whether index testing would perform same way in different geographic settings. So because in Ghana, there are differences in terms of the socio-cultural context in different regions. When you move from the south towards the north, there are economic variations, there are cultural differences. We realized that applying index testing and some of the new modalities that require partner notification performed almost equally in terms of increasing awareness, increasing yield in the various regions. We thought that it is because of the contribution of members of the KP community and civil society organizations that inform some of our approaches and the soft skills that are used by the cadre of index testing staff to approach members of the KP communities.
Henry, I'm going to ask you to try to wrap up in the next minute or so. I know there's a few more slides. Thank you.
In the age distribution of the clients that we have, you will see that on the right we have yield coming from those from 40 to 50 years. And so going forward, we are focusing on this hidden population that has more money, if you like. They are economically within the high socioeconomic bracket. I would like to say that index testing, when you look at this graph, index testing and helpline counseling have been the key approaches that have given us most yield. Field challenges that we've had in integrating this testing into the KP program, issues of confidentiality, what we call first thoughts, where people think about where is the infection coming from and the anger that comes around with that, informing the partner, in this case, playing about money, time, and the psychological energy involved, and then the know-how in disclosure. These we think that had to be focused on as we continue. In terms of way forward, we continue to dialogue with the Ghana Health Service and Ministry of Health to ensure that these index testing can be adopted. We would continue to scale up training and improving curriculum and contextualize it to make sure that it's fit for our purposes, and support all partners in country to learn from our experience and to contribute to the national response in Ghana. Thank you.
Thank you, Henry. Really appreciate that. And again, a reminder to everyone, please mute. I've heard a couple Skype beeps, so I'm wondering if some people are not on mute, and it will help us all with the audio. Thank you. Again, we look forward to your questions in the chat box for Henry. The next and final presentation is from Repsina Chitalova-Dallas, with whom I've had the pleasure to work with on the AIDS-Free project. Repsina is one of our senior technical advisors, and she's going to speak about key resources which are available to assist programs to increase quality and scale of both index testing and partner notification in the continuum of care. Repsina, over to you. Thank you.
Great. Thank you for the introduction, Barbara. Hello, everyone. It's my pleasure to be presenting at this webinar today. In this final presentation, as Barbara said, I will talk about some of the resources on index testing and partner notification that we have here at JSI and that were developed by various JSI-led projects, including the AIDS-Free project, where I work. All right, next slide. So AIDS-Free, for those of you who may not know, AIDS-Free is a 5-year USAID-funded project with an overall goal of building sustainable country-owned HIV programs that align with international targets for epidemic control. We achieved those goals by focusing on various technical areas, including HIV prevention, diagnostic, care, and treatment. In the countries, we work collaboratively with national governments, with private sector, with community organizations. We provide capacity building, infrastructure strengthening, and service expansion with the goal of reaching men, women, girls, boys, and key populations. The first resource that I would like to speak about today is the Partner Notification Handbook that was completed and published on the AIDS-Free website last year. The handbook is a practical resource document that complements the 2016 WHO guidance on partner notification and HIV self-testing. The handbook provides best practices, models, challenges, and solutions from 8 different countries. The intent, when we first thought of this document, the intent was that this will be a very practical resource that will help program managers, the policymakers, healthcare workers, trained healthcare providers to develop policies in countries that don't have policies on partner notification and index testing, and then introduce and roll out index testing and partner notification. The handbook includes very specific examples how some of those 8 countries achieved that, and then we also included the forms and templates that could be used or adapted. All of that can be found on the AIDS-Free website. The handbook can be downloaded, printed, so it's a very user-friendly format. The next resource I want to talk about is the HTS knowledge base. Within this knowledge base, we have two entries, one on index testing and the other on HIV self-testing. Again, the knowledge base is what we think is a resource library of documents, which can help identify considerations when programs are thinking about introducing, rolling out, or scaling up assisted partner notification and index testing. We at AIDS-Free collaborate with the WHO HIV and Global Hepatitis Program to update both of these knowledge bases on a regular basis. Currently, we have about information from about 18 countries, and hopefully more and more will be coming and added to the knowledge bases as more countries roll out and scale up index testing. So I encourage you all to check in on the AIDS-Free website often and let us know if there is anything from your specific countries. You know, we're always looking for very specific information, for examples, for templates, resources. So send them our way. We'll be happy to take a look. The resources are organized into major categories, such as what we know, country experiences, tools and curricula, monitoring and evaluation, examples from AIDS-Free and other PEPFAR-supported programs, and country policy guidance. Again, both of those knowledge bases can be found on the AIDS-Free website. Moving on, the next resource I would like to talk about is the index testing flowchart. This was developed by AIDS-Free and the Advancing Partners and Communities project, and is based on our experience working to roll out and document index testing. The original our goal as we were working on developing this flowchart was to help our country programs to collect correct information, and especially for those of us working on PEPFAR-funded programs, to make sure that the data collected is aligned with MERS for data submission. Just take a few seconds to take a look at the flowchart, the way it's organized. It outlines every step of the process. And here I want to show an example from a project, a JSI project in DR. This is how our project used the flowchart to document the information and then to share this information with USAID, but also within their own team to see where they are at each step of the process and where improvements could be made. Based on this flowchart, you will see that while only 1.3% were reached through the voluntary partner referral index testing modality, it actually contributed 9.6% of all positive results during that quarter, with a consistently high HIV yield of 28.4%, compared to 3.5% for all non-index testing during the same period. So this clearly indicates the effectiveness of the VPR strategy, and is consistent with data indicating that HIV prevalence of sexual partners, of people living with HIV, is higher than prevalence in the general population. So this is an example to show how this chart could be used to both report the data, but also to see for the programs to continually monitor where they are, which step of the process needs to be improved. The next and final slide is on the AIDS-Free guidance database. The database is also on the AIDS-Free website, and it currently includes national guidances from 47 countries on consent, on confidentiality, testing algorithm and strategies, use of mandatory testing, self-testing, and quality assurance and quality improvement. Can be accessed through the AIDS-Free website, and all documents are available to be downloaded and printed. So these are some of the examples of the resources we have available, and encourage you to use and to check often as we're working to update them regularly.
I'd like to also thank the presenters for for the work that they've done and sharing their expertise. In the next few days, you will receive an email with a link to the recording of today's presentations. And before we close the room, I would just like to encourage you to take a moment to fill out a poll of questions that has just been posted and provide us with feedback so that we can improve webinars in the future. On behalf of JSI and our presenters, thank you all very much for your time and for all the work that you do in the communities in which you work. And we will continue our collaboration. Thank you.